given us a problem. Here is a patient, man 43 years of age, obese, hypertension, the BP of 160 by 100 millimeters of mercury during his current visit to my office. He is on therapy. Is it resistant hypertension? How many of you think it is resistant hypertension? Very few. How many feel it is not a resistant hypertension? I think all of them are still thinking what is to be considered. Let us see how Dr. Venkatesh is going to discuss this topic.
Good morning, ladies and gentlemen. Patil sir, thank you so much for that perspective, the enormity of hypertension problem in our country. I thank Dr. Nagaraj Desai and Dr. Prabhakar for inviting me for this small talk. Now, this, Dr. Desai always gives a very simple question that shows what kind of a teacher he is. From that simplest of the question, he takes out the most complicated answers. So here is the man of 43 years of age, obese, hypertensive, BP of 160/100, and that is when he visited Dr. Desai. He is on treatment. Now, is this resistant hypertension? On the face of it, it looks like it, but let's go and see what else is there. The fundamental question here is this apparent resistant hypertension, resistant hypertension, or is it true resistant hypertension? Of course, there's another category called refractory hypertension where more number of drugs are required. But to answer this question in this particular patient, we need more data. So the examiner has not given data. So as a good student, what I'll do, I'll enter the staff room, hack into his personal computer and see the data. What else is there? So the definition for resistant hypertension is it's uncontrolled even after taking 3 antihypertensives in maximum or maximally tolerated doses, including 1 diuretic. But what is happening here? This is what I found on his computer. He's a 43-year-old male, no history of ASCVD or diabetes, BMI is 33. And currently he's on telmisartan 80 mg, good dose, amlodipine 5 mg BD, good dose, and hydrochlorothiazide, a diuretic. So it technically looks like resistant hypertension. In fact, I even got a picture of the patient and the doctor in that computer. Now, it seems that the current regimen, kind of fulfills that definition of resistant hypertension. But is this enough to make a diagnosis of resistant hypertension? What else is needed? We have to see. What else should we rule out? We have to see. Now, the target BP, that is an important thing. In the ACCHA guidelines, the target BP is 130/80. So if somebody is not reaching that target, they are called as resistant hypertension. But in India and in Europe, 140/90 is the target. Merely changing the target BP changes the prevalence of hypertension. So when we define for different categories, we have to say what is your target, and based on that, we say whether this particular patient is resistant to treatment or not. In India, Indian Society of Hypertension says 140/90. Is the BP being correctly checked in our office? When the patient comes, is he being seated properly, is back supported, leg? All of these, the technique of checking the blood pressure in our office has to be seen before we declare a patient. The patient comes running, fights with the cab driver, fights with the receptionist, gets into the nurse's room. The nurse has to check BP of 10 people, and there is not enough time because the whole process of taking a BP takes about 10 minutes. But that amount of time is not there, and because of that, we wrongly estimate the BP in the office. So there also we can wrongly classify a patient as resistant hypertension. So there are certain rules for taking blood pressure. All of these have to be followed in our office before we say blood pressure is not under control. There is another entity called white coat hypertension, we all know. Sometimes it is not truly a white coat hypertension because we are in a hurry, we wrongly do that. But if we take the blood pressure correctly, in spite of that, if the blood pressure is high in the office, but at home the blood pressure is better, it's white coat hypertension. So we could be simply dealing with a white coat hypertension rather than a resistant hypertension. In one of the studies from Spain, they found that out of 8,000 or 9,000 patients, 12 of them were office resistant. But when they were actually studied with ambulatory BP monitoring, nearly 40% of them turned out to be white coat hypertension and not true resistant hypertension. So when we see a patient with high BP and we think it is resistant hypertension, we should also rule out white coat hypertension. The other thing is the patient taking the medicines? You know, he says that I have taken the medicine, but is there adherence to the medication? So there are studies which have shown that adherence is really low. Adherence was lower in younger patients, male patients, and those who are on diuretics are more than 2 or 3 pills. So therefore, adherence has to be checked. In fact, in one of the trials, this is a renal denervation trial, whether the patient received renal denervation or was on control group, fully adherent population was only 50%. So of our patients, many of them are partially adherent, some of them are non-adherent. Because of that, we may be wrongly classifying a non-adherent patient as a resistant hypertension. So that's adherence is one more thing which we have to check. These two, both of these two, the white coat hypertension and adherence to drugs can be looked at by using ambulatory blood pressure monitoring. One, it rules out white coat hypertension and identifies true resistant hypertension. There is also some data which says that ABPM can detect non-adherence, and also once we start monitoring patients on ambulatory BP monitoring, their compliance and adherence to drug therapy improves. So the other commonly overlooked causes of pseudo-resistant hypertension are these: obesity, sleep apnea. Dr. Deepak is going to talk about it. Concomitant medications and substance abuse we have to look at. Hyperaldosteronism, Professor Sunil is going to talk about it. I'm not going there. Renal parenchymal disease, renal artery stenosis, and other causes of secondary hypertension all have to be ruled out. Now, renal causes are always looked at. The first thing we do in a hypertensive is to do a creatinine. But one thing we have to understand is, if somebody has a creatinine of 1.3 this year, let's go back and see his last year's creatinine. If it was 0.6, we may be looking at CKD in an incipient stage, where that could be the reason of secondary hypertension. So this has to be borne in mind, though of course everybody checks for both CKD and renal artery stenosis. Renal artery stenosis is a small number of patients with resistant hypertension can have it. We all know that it's suspected in younger patients or in older patients who are very resistant to blood pressure. A Doppler can easily tell us whether there is renal artery stenosis, and it's many times treatable either with an intervention or with aggressive medication. Concomitant medication history is something which we have to obtain. There are patients who are with arthritis taking NSAIDs. Sodium-containing antacids are commonly used. In women, sometimes oral contraceptive agents are taken by the side. They have not revealed or we have not asked. Cough syrups are important cause of sudden shooting up of blood pressure. Alcohol is very commonly missed. People underreport their drinking habits. Somebody is drinking every day but doesn't admit to it, and blood pressure is not under control. Some of these are important causes of hypertension which looks like resistant, but it is not really resistant. Primary aldosteronism is reasonably common in patients with resistant hypertension. It's a rare condition, but common in young resistant hypertensives. Here we look for serum potassium. Hypokalemia is seen in these patients. Plasma renin level will be very low, aldosterone levels will be high. So therefore, aldosterone-renin ratio will be used for diagnosis. If we find this aldosteronism, CT or MRI is to be done, because half of these patients are treatable surgically, and these patients are treated with mineralocorticoid receptor antagonists. Now the question is, in any case of resistant hypertension, we are always going to add a mineralocorticoid receptor antagonist. So why should we check renin levels or aldosterone-renin ratio? There is some literature which says that the harms of primary aldosteronism are not just because of the blood pressure itself. There is stroke, myocardial infarction, and renal risk of Conn syndrome, even when the blood pressure is well controlled. So there are other hormonal effects in play. So therefore, diagnosis of this condition is important, and it is an easily treatable condition. Pheochromocytoma is spoken about. I am bringing it up mainly for the reason that we keep checking plasma catecholamines, urinary metanephrines, and 24-hour VMA. these are very unreliable tests. If we suspect pheochromocytoma in a patient, screening is with plasma metanephrines only. So if that is 2.5 or 3 times more, then only we go on to the next step of identifying or diagnosing pheochromocytoma. Otherwise, in resistant hypertension patients, going on doing the other tests, the plasma dopamine, the catecholamines, urinary metanephrines, or 24-hour collection of VMA, it's all waste of time and money. Salt sensitivity is one more thing which we have to look at. There are some people who are highly salt sensitive. So before saying somebody is resistant hypertension, we should check their salt intake, ask them to cut down and see if there can be a better control of blood pressure so that patient can be reclassified as non-resistant hypertension. There are many other causes of secondary hypertension. I'm not going to go into great detail, but these are the common ones which are also looked for so that secondary hypertension can be diagnosed. When all of these are ruled out, then we say that this is truly resistant hypertension. So there is a good review article in Hypertension 2018. It gives us a pathway for evaluation and management of resistant hypertension. It's a wonderful article. I urge you all to go through that. Resistant hypertension is a reasonably common condition. It carries serious adverse prognosis. Very important is to accurately diagnose it, and we should exclude pseudo-resistant hypertension, and we should talk openly with the patient about adherence, compliance, need for good control, and only then we can kind of improve the management of these patients. Tools like home BP monitoring, ambulatory BP monitoring, tests to rule out secondary hypertension, and we should have a good knowledge of what agents will work in these patients. This is very important. Thank you very much.
Thank you, Dr. Venkatesh, for excellent lucid talk.